We welcome you to the course on the topic on management of the cervical spine syndrome. I'm called retired Major Jean Damascene Cervical. I'm a specialist, specialized in orthopedics and a consultant in OMT, orthopedic manual therapy. So the course we are going to talk about is about, as I said, the management of cervical spine syndrome. You will understand why it is called the syndrome. So let me start first of all with some presentations that into the topic. When you look at you are familiar with this the cervical spine. You know the spine has three parts: cervical, thoracic, and lumbar. So we are going to focus on this. But as you know, the spine, it's not just limited to this. It's work as a continuation. So there's you cannot just talk about the cervical without considering other joint attached to that works with it. So this is the cervical spine with 7 vertebrae, and you can see there. It's clear when you see the artery, the vertebral artery that passes through enters through the C6 and goes up to until it becomes the vertebrobasilar artery and into the brain. It's very important here to retain, because there is a condition that can be caused by the degeneration of the vertebra at this layer. Spondylosis of this level, at this level, can cause problems in headaches, what we call cervicogenic headaches, or vertebrobasilar artery insufficiency. So this is a typical vertebra, as you know, with all the foramen, with all the body, the spinous process, and it's specific to cervical. Why? Because of the movement the cervical is supposed to do. And we have a specific to vertebra, the number 1 and number 2, which is atlas and the axis. So they articulate through the dens, also very important, and they allow the rotation of the head on the neck. So quickly about the biomechanics. When we want to talk about biomechanics, we need to consider stability versus mobility. On the cervical spine, they are both. The cervical spine move, you need to do a lot of movement, but you need also to stabilize that area because it supports the weight of the head. And the weight of the head is between 3 and 5 kilograms. So we can have different mine maybe is small, but that's the range between 3 kilograms and 5 kilograms. So stability is due to active ligament and also stabilizing muscles. But we have the position, the cervical also position the head during vital function, like sleeping, like eating, like whatever you do using your head. So mobility also is due to loose joint capsules. They are not tight, they are loose to allow movement. We have a postural alignment and balance, which is responsible for the proprioception. They are important also. The spine functions as a closed kinematic chain, as I was saying. You cannot just consider cervical, you need to consider the thoracic and also the lumbar. Anything that something in the deformity can start at the lumbar and later on affect the cervical. For example, the cervical is influenced by the thoracic and also the shoulders. Very, very important, because there are some muscles attached on the spine that goes also on the glenohumeral joint. Also, the temporomandibular joint, this one, it's also affected, can be affected because it has a close relationship with C1. So whenever you have a problem with C1, you can end up by having temporomandibular joint pain. And then, especially when you have a deformity at the level of the thoracic, which end up by having a poking chill like this, it's going to stretch the temporomandibular joint, which is going, when it is stretched, later on you are going to have to start having pain even when we are chewing. Yeah, quickly, the biomechanics again. So therefore, the cervical spine is designed for mobility. for mobility. And it's not subject to the same magnitude as weight force and flexion as the lumbar, because support only the head. For example, the cervical facet joint are oriented in a plane, more involved in weight bearing, and intervertebral discs are more fibrous biomechanically, which differ to the lumbar. Why? Because at the level of the cervical spine, you have a small disc. That's why you need to have more fibrous. The annulus fibrosis is big compared with the lumbar. So the disc herniation is then less frequent. So quickly, as you go into biomechanics, this is the picture that you know. The disc, as I was saying, the disc there, the annulus fibrosis, and the disc inside, and you have the posterior longitudinal ligament at the back, and the vertebral body that you can see. The nucleus is very small, as I said, to lumbar. Compared to the lumbar, the annulus fibrosis develops sometimes horizontal fissures posterolaterally toward the end of the first decade of life. So from the end of from 9 to 10 years, because of the cervical spine started to carry the head of the weight of the head, it started already to have some fissures posterolaterally that sometimes may extend to the posterior third of the disc very early in adult age. We see what they said around 25 years. You start already without any injury. That's how. That's the advanced age at the level of the spine starts. So these annular fissures are usually normal in the aging process, leading sometimes to a condition called cervical spondylosis. And each nerve root leaves the spinal cord, as I said, the foramen. These are the anatomy, which have capsular ligament, and all that form together the joint and the movement of at that level. So these ring fibers, after 25 years, the fibers around the annulus fibrosis, they start to degenerate after 25 years. And it is now common when people are using telephones like this, and others are carrying heavy bags. For example, in our rural village, they carry heavy bags which increase more load on the cervical. This can lead to the spondylosis. And then later on, you can end up with a protrusion. And when the nuclear material reaches the edge that we have, it can reach the posterior longitudinal ligament I showed you, and it can pierce into the spinal, and then reach the spinal cord, and you get a hernia. Only 1/3 of the outer layer is innervated. So as long, it means, here you need to follow very well. It means you can start having degeneration inside the disc. You are not aware of it. You only start to feel it when it is already at the outer layer, 1/3 of outer layer. So it can start early. You don't feel it because of bad posture, because of many other factors, and then you will start to feel it when it is already far. You see. When I go back here on this, you see, if you say 1/3, it will be like 2 layers before you end. You see there. So now they said compression of the nerve root then causes herniation. Let's continue. Now, movement of for the movement between the head and the occiput, the head and the atlas, you have flexion and extension. It's only 1/3. They provide 1/3 of flexion. Between atlas and axis, you have the half of the rotation, or the full amplitude of rotation. It's provided by the movement between atlas and axis. Remember, there is a dance in between that allows that rotation. All other parts of the degrees of rotation are provided by the rest of the vertebra. That's why you have, that's for the upper spine, because the upper spine, it's the first two, and the lower spine, you start from the first 3, and the lower spine, you start with C4, 5, and 6. So these are the different movements you can have. The